Hi, good evening, everybody. My name is Eddie from the FAST event. Thank you for joining us this evening for our very first webinar series. Today, we are very honored to have invited Dr. Sophie Menkes, Professor Magalon, and Dr. Jeremy Magalon to be the presenter for the first webinar for this session. For your information, we will have three panelists. We will start with Dr. Sophie Menkes from Switzerland. As you can see from the screen, her topics will be indication, the first consultation, the necessary paraclinical examination, the collection of data. Then we will move on to Dr. Jeremy Magalon, and we shall end the presentation by Professor Magalon. After which we will have a Q&A session where all of you, I would encourage now, after listening during the presentation, you can put your questions into the Q&A chat group or the chat. So we will be able to capture your questions. Then from there, we will share the questions at the end of the last presentation by Professor Magalon. So we shall start the presentation by Dr. Sophie Menkes from Switzerland. I shall stop share my screen now, and you can start sharing your screen, Dr. Sophie Menkes.
So, hi everyone, I'm Dr. Sophie Menkes. I'm the medical director of the Center of Aesthetic and Regenerative Medicine in the Clinique Naissance in Switzerland. So we are going to start by clinical application and first of all, the consultation. Consultation is very important because you will explain to your patient what we can achieve with regenerative medicine. Of course, we start the consultation by asking what are the concerns of the patient, what are the needs of the patient. Of course, ask them if they have any disease, if they take medication like anticoagulant because they have to stop before the procedure. It's very important to explain what are the benefits and the risks of all procedure and why we want to choose regenerative medicine, why regenerative medicine is the best in their situation. And then we go to the clinical examination, to the assessment of the patient to evaluate what the patient needs and what the patient wants. So it's a very important part, and also we can do the treatment plan and of course give our patient the estimate. What are the indications? A lot of indications. Of course, all skin issues and facial, neck, décolletage, hands, but also acne scars, stretch marks, hyperpigmentation, specifically in the tear trough area. It's a very good indication. Inflammation like acne rosacea or psoriasis, we have also very good result on the hair loss and of course vulvovaginal rejuvenation. So first of all, hair loss. Hair loss, you know that it's a very huge amount of patients, 70% of male patients and 30% of female patients have hair issues. It's very important to collect data because before and after picture, it's also important because you will see the improvement, but we are scientific, we are doctors, so we need to collect data. First of all, for the patient, because some patients, they don't see anything on the picture, and also for us, because if we want to publish, if you want to protocol, we need data. So at the clinic, we use the Tricolab analysis, so we will have the hair count, and we will measure the diameter of the hair, And also we have a diagnosis of, for example, in this case, androgenetic alopecia. So it's a very easy, it's only a few pictures, and then we have everything. We have the conclusion and we have the hair count. So we can see every 3 months if we improve or not the number of hair, the diameter of the hair. So this is the result we obtain on all areas. This is a picture before and after 6 months. So you can see that we achieve a very good improvement without, of course, the tricoscan analysis, because it's obvious. But as I told you, it's better to have the hair count. Of course, we use PRP because if we add PRP to our product, we will improve proliferation and differentiation of the cells. It's very important to obtain a characterization of the cells and to have a cell count. So we use the Axon Lab device, and we know exactly what is the number of the platelets, and we know what is the dose, and the patient, they will have the paper at the end, and they know exactly what we are doing. So I think today it's not possible to inject something to a patient and we don't know what it is inside. So with Remedex, and maybe Jeremy will talk about it later, we know exactly what is the dose we have injected to our patient. Facial, neck, décolletage, hands, and skin rejuvenation, it's the most important demand of our patient. So to evaluate, first of all, this is a visual scale. So we ask the patient to feel this visual scale, and as you can see, the patients are very happy with the result. We have also the scale to evaluate our hands treatment with the scale from Merz. And also we use the quantificator. With the quantificator, you will see we have a reconstruction of the face. So there is no story of light. So the patient, they cannot say, because it's not the same light. And also we have the micro photos, and with the micro photo, we can measure also the depth of the wrinkle. So this is a standard picture. So we do it in the room without window, with spots and no flash. And you can see that this is a reproducible picture, and this is the result at 30 days of nanofat grafting. And this is the result of the quantificator. So you can measure the lifting effect of our treatment. So after 3 months, you can see that we achieve a very good lifting effect. And some patients really needs it to evaluate the result. So you can see the result after 3 months on the skin. This is a slider. So it's a very useful tool for us, for publication, but also for the patient, because some patients, they say, I don't see anything. And when you show those kind of results to the patient, it's impossible for her to say, I can't see. I don't see anything. We can measure also the pigmentation, inflammation, and we can also measure the depth of the wrinkles. So this is really an objective tool, very important. For vulvovaginal rejuvenation, we use the speculum Colin 33 millimeter for the examination of the vagina, and we use also the pH control Elaine. So the first scale we use is the Friedman score. This is an objective score, and we measure elasticity, volume of secretion, pH, integrity of the epithelium and hydration. So this is why we need the speculum to evaluate the elasticity and the epithelium and the volume of the secretion, and then the Elaine pH to measure the pH and to have a score. And the second score is the female sexual distress scale. It's a 13 question about how they feel, and as you can see, it's a very difficult question, and a lot of women, when the answer is 4, we know that they suffer. It's very important to have a score and to have a quantification of the suffering of the woman and to measure the improvement. This is a before and after picture of nanofat grafting. So as you can see, we have tools. It's really important to measure what we are doing, not only for patients, but also to collect data, to share data, to publish, and to move forward in the regenerative medicine. Thank you for your attention.
I cannot hear you, Eddie.
Sorry. Okay, thank you very much, Dr. Sophie Menkes, for your presentation. Now we would like to invite Dr. Jeremy Magalon to share his screen for his second presentation. Yeah, please go ahead.
Thank you, Eddie. Thank you for the invitation. So I'm Jeremy Magalon. I'm PharmD, PhD, and I'm working in the University Hospital of Marseille, and I'm specialized in cell therapy and regenerative medicine. I want to introduce today what will be the main topic of the FATS Congress in June, which is what I call the concept of point-of-care regenerative medicine. In fact, the use of stem cell is now extremely hype, extremely popular, and we have sometimes some amazing news with, for example, people that are able to walk again after paralysia, or some secret treatment like the famous Michael Schumacher that gets stem cell therapy in Paris a few years ago. And you can see that during the past 20 years, regularly the famous Time newspaper was able to talk about the revolution of stem cells. In fact, there is not only stem cells and cell therapy, which is a transplantation of cells to develop new tissue, but you can try to mix that with another science, which is the tissue engineering. And when you combine these two fields, you are able to get the regenerative medicine, which is an emerging field in biotechnology, whose goal is to renew tissue and functional activities. And I like to say there is two kinds of regenerative medicine. One kind is more industrial for rare and serious indication, which are extremely expensive, with sometimes immunogenicity issue when you are using tissue or cells from which are not autologous, where you need to do clinical trials that refers to the ATMP regulation, and you need to prepare all that in GMP authorized facilities. And what happens in the past 20 years, thanks to a pioneer surgeon, is the point-of-care regenerative medicine. It's much more simple, point of care during surgery or consultation. It's also autologous. It means you will use the cell or the tissue from the patient directly, and you use only medical devices that are adapted to prepare the product you will re-inject to your patient. And in fact, in the body of an adult, you can use blood to prepare PRP, PRF, eventually to use the serum from the patient. You can collect bone marrow to prepare bone marrow concentrate, or you can use adipose tissue to prepare fat, microfat, nanofat, and inject this product to your patient. And as I told you, all these procedures were developed by pioneer surgeons. So Robert Marks is a maxillofacial surgeon, a US maxillofacial surgeon. Philippe Hernigou is a French orthopedic surgeon and is the father of the use of bone marrow concentrate in a regenerative procedure. And Sidney Coleman is a US plastic surgeon, and he was the guy who has standardized the lipofilling procedure. And it's interestingly, when we have a look to their pioneer paper, so it was for all of them just before the 2000, they have very standardized procedure, a precise description of all the steps, scientific publication, biological data, and objective assessment. Finally, all what Dr. Menkes just described in her routine procedure and daily procedure when she's doing point-of-care regenerative medicine. And so also it's important to have in mind that from these different tissue and the different products, some of them are more easy and faster to prepare, like all products that come from the whole blood. And then you have a more invasive harvesting procedure with bone marrow and adipose tissue. From the adipose tissue, you can only extract the famous stromal vascular fractions that contain all the regenerative cells. And finally, if you are using and if you are dealing with bone marrow or adipose tissue, you can put that in culture and have cultured mesenchymal stem cell, which is longer and more complex. A word about what are exosomes. You know that exosome is only finally one part of the global cells, of the membrane of the cells that will move from the cells and bring with them biological material and will have biological properties. So you don't have anymore the nucleus within the cells. There are more and more publications about exosome, more and more companies that are trying to industrialize exosome product. And finally, it seems that this exosome could have advantage compared to the use of the global cells. For example, because you will have no differentiation, no replication of the cells, no vasculature inclusion. It's allogenic, so it will be ready to use. And what says the scientific community is maybe in the future it will be easier, cheaper, and safer to make regenerative medicine. So this is my last slide. The idea would be to tell you what we'll try to learn to you during this Congress. You will have a lot of details about the best practice for preparation, quality control of all the autologous regenerative medicine point-of-care procedures, from PRP to enzymatic stromal vascular fraction. We will share with you updated literature and industry perspective in the field of, which is a very hot topic of exosome. And you will have also step-by-step procedure for clinical surgical application in the main clinical field where these regenerative products are used, meaning aesthetic, dermatology, and musculoskeletal field. Thank you for your attention.
Thank you. Thank you, Dr. Jeremy Magalon. So for your presentation. Now, at the same spot, we would like to invite our final presenter, Professor Guy Magalon, to share his slides. Thank you very much.
Okay. Good evening. Happy to be with you for this webinar. And I want to explain what are the products used in regenerative medicine. You know, that is a list. You have first the PRP, very well known. After you have the millifat. The millifat was the idea of Sidney Coleman. And we move on the microfat, where the parcel of fat are smaller. We have also the mechanical preparation of fat to prepare a new product with the stromal vascular tissue or nanofat by two processes. One is emulsification and the other micronization. We have also the stromal vascular fraction with preparation with enzymatic digestion. You can also prepare stem cells. And now we have the big field of exosome that will be one of the topics of the meeting. like to use autologous products because there's no risk to use autologous products. It's quite easy to prepare. We develop a technique to harvest the fat with a closed system. We are working on an automatic device for large volume samples, and we have also used automatic device for enzymatic digestion. With all this possibility, you can develop a strategy with cell-assisted lipotransfer. And for example, for this course, Aris Theodimas is one of the leaders of cell-assisted lipotransfer. You know, the platelets are very small, 2 at 3 micron. It's no nucleus, and you have a big number of platelets. The dose injector are in hundreds of millions, even in billions of platelets. That is all the product we can use: millifat, microfat, preparation of fat. With mechanical preparation, now we have around 7 devices on the market with all different possibilities and different products, and you obtain the SVT, stromal vascular tissue, and you can also modify this tissue to prepare gel like yao or lipocondensation like Palua, or to talk about stromal aggregate. It's a new big possibility. You can have stromal vascular fraction on the side. It's prepared with enzymatic digestion, and with both products, you can have mesenchymal stem cells, and you can mix this product. We have also some new idea about the use of stem cells and regenerative cells with artificial dermis or acellular adipose matrix. That is the closed system. You go directly from the fat with a three-way coke and a syringe of 10 cc in a bag. In the bag, you can do a purification, and you have a very nice product. That are the automatic device for large volume with vibrating cannula, the body jet with very nice device, and we can talk about body jet, the Alma laser, where we have a fiber at the top of the cannula with a laser, and the molar, where you have the possibility to infiltrate hot physiologic serum to have a better anesthesia. For the stromal vascular fraction, the first on the market was a solution. Now the solution is a device in China with the company Lorem Satori. We have the ACSTM from Korea, and the QGRA from man-made, the G technology, and they all devise the CEPAX. The stromal vascular fraction is a very nice product where the viability is around 400,000 cells by gram of adipose tissue. And if you want, you can inject IV or intraarterially this product if you obtain the authorization. It's possible in some countries, and that is a big debate for the next course. In Europe, we have a law which is very strict. If you have a substantial manipulation, or if you are not that we call homologous use, you are advanced therapy missile product, and you need to have authorization from the authority. It's like that in a lot of countries. After, you can mix the product. You can mix your product with PRP, with stromal vascular tissue, with stromal vascular fraction, or with cultural stem cell. You go from an easy, fast, and viable procedure to a difficult, long, and expensive procedure. The new idea is the utilization of this product in all the specialty. The more advanced are maxillofacial, plastic, and ENT, but you can use in dermatology, in endocrinology. Orthopedy is a big field, and it's very interesting. Urology, gynecology, gastroenterology, and the last field will be cardiology and neurology, or probably it's a lot of indication. In conclusion, cell therapy products are manifold. Their preparation requires rigorous protocol. We start with plastic and surgery, but we move on all specialty. When you use a TMP, you have substantial manipulation, and you need a very strict regulation. And the evolution for the last 20 years was from enzymatic stromal vascular fraction to mechanical modified muscle fat, micronized fat, stromal vascular tissue. The idea to use stromal vascular fraction or stem cell in systemic use, to have also the possibility to do stem cell expansion system. Some companies are working on allogenic stem cell, and now we have the new field on exosome and cryopreservation. We want at this course and this congress give you all this information that you can use all this product with rigorous protocol and very good safety. Thank you very much.
Okay. Thank you very much, Professor Guy Magalon. Okay. Right now, it's open for session for the question and answer. So, if any participants want to ask questions, you are welcome to do so. Okay, maybe there's one.
I think there is
yep. There's one question from Dr. Ruth Wong Trung Kapu. I guess it's from Thailand. Is that I think this question is addressed to Dr. Sophie Menkes. The question is nanofat graft microneedling for hyperpigmentation and wrinkle at labia majora. What do you think in case that use the microfat graft for labia major contour correct? I think these questions has been answered by Dr. Sophie Menkes. The answer is if you want to improve pigmentation, you have to inject nanofat. Microfat will only improve the volume. Okay.
Yes, exactly. Because we have not the same properties from the nanofat than the microfat, specifically on the regulation of enzymes such as tyrosinase and cyclooxygenase, and also the regulation of the immune system that we have with the nanofat, but we don't have with the microfat. This is a study from my colleague, Dr. Banya. He published this, but I can tell by experience that if you inject the microfat in the labia majora, you have no change at all on the color, on the pigmentation, and if you inject nanofat or exosome, you will improve the pigmentation of the labia majora.
Right. Thank you, Dr. Sophie Menkes, for the elaboration of the answer. There's another question came from Ahmed Alilo to the host. Any study about the biological activity for the stem cells after harvesting and re-injection in the body? Any presenter want to answer this question?
So I can tell that we published that we have a lot. We have exactly the same when we compare the stem cell from the stromal vascular fraction and the nanofat. We have no significant differences, and we published in the PRS. But there is a lot of publication on this topic. So maybe Professor Magalon wants to answer. But we published this in the PRS.
I think there is a lot of publication detailing the biological activity of stem cells, but it's difficult to say exactly how it works after injection in the body. But for sure, we know that stem cells, and particularly mesenchymal stem cells that we couldn't find in the fat, have pleiotropic biological activity by the secretion of active factors, so angiogenic, antifibrotic, that also is able to promote local progenitor proliferation. If you go on PubMed, you will find a lot of information. It's much more difficult to know exactly how it works once it's injected, but for sure there is biological activity because as you will see during the Congress, there is amazing clinical results after injection.
Question came in. What is the difference between SVF, stromal vascular fraction from enzymatic process, and mechanical non-enzymatic process? To further elaborate the question, which one is better? This question is from Dr. Komar Ardi Wayunise.
I think it's two products who are totally different. At the beginning, we start to use stromal vascular fraction, who was an enzymatic preparation where you need to have a lab of cell therapy and authorization from the authorities. And this product was very nice. We use this product in some indication like scleroderma, like Crohn's disease or vocal cord, and that was a very nice product with it's a product with liquid, and the possibility also is to use this product IV and to give stromal vascular fraction IV. When they discovered mechanical preparation, and that was in 2013 by the team of Belgian people from Tonar et Verpel. They say that this product will be very interesting because you can go in the very small wrinkle from the upper lip. And the idea, it was just to have something smaller than fat, with more liquid, where you can go through 27 to 30 gauge needle. But it was just at the beginning for wrinkle. And we have seen that, in fact, in this product, I like to call this product stromal vascular tissue, because in fact, inside you have some parcel of cells, you have oil, you have destroy adipocyte, but you have also the same regenerative cell that you can find in the stromal vascular fraction. And you cannot inject this product IV because it will be dangerous to have arterial obstruction. And the difference is the products are totally different and they have not the same name: stromal vascular fraction and stromal vascular tissue. But the stromal tissue is very active to improve the quality of the tissue. And the main difference, you no need authorization to do that, and the price is really cheaper. I think it's from a ratio from 1 to 10 for the price. And that is, it's very interesting. And now we are 10 years later, and at the beginning, it was just a manual preparation, and now we have different kits of the market. Some kits are for emulsification, and the others are for micronization. And the idea is to destroy one part or the total part of adipocyte, and that is in discussion. It's
Thank
okay for. Alors, la suivante.
Yeah, thank you very much, Professor Guy. There's another question from Dr. Ruth again from Thailand. This question is addressed to Sophie. Do you think for nanofat graft injection at G-spot in vagina?
Yes, we are doing it all the time, and we have a very good improvement, and the patients are really happy with the result.
Okay.
Sophie, I have one question more. It's a nanofat, or you put a little bit of microfat?
I did it always with nanofat, because with microfat, we have always the risk of obstruction of the urethra. So I started with nanofat, and since I have very good results, I don't see why I will take the risk of injecting microfat just near the urethra.
Okay.
Okay. This is interesting again. We have another question coming in. Do you think stem cells derivatives will replace the standard current fillers in increasing the volume in face, for example?
I can tell that the answer is yes, because since the last months, I see more and more patients, they don't want to be injected with fillers anymore, and they ask for microfat grafting. And I can tell I was really surprised. 2 weeks ago, I saw a patient, and she came and she asked me, I want a microfat and nanofat treatment. And I was surprised, because it was the first time that a patient, they come and asking for microfat. And I said, what are you, why are you asking this? How do you know this? And she told me, because we discuss with my friends. And I said that now the patient, they talk about it, and we will have more and more patients, and they are really aware of the side effect on the fillers, and they want something natural, something long lasting, and they don't want to have to take risk with the fillers anymore.
That's good. Maybe FATS can consider to have a session for patient on top of doctors in the future to educate the patient. Okay. I think we have a question from Peter Jong. Do you have a question, Peter Jong?
He's on mute.
He's mute.
Yes. Peter, do you have a question? All right. I think there is there anything you want to share, Professor?
I think if you have no more question, you know, it's we know we are working on fat for more than 20 years, and we have seen a big evolution on the possibility. We are sure that this process are very effective, and you can treat a lot of disease. But you need to know the different products, and you need to know how to harvest the fat with good condition, and to prepare the product. And it's a lot of details. And the idea of the course we want to organize with all this team and with Eddie is to give you the best practice at the moment. And it's a nice evolution, and probably it will not repress totally the fillers, but it's a new way, because you improve a lot the quality of the skin, for example. Oh, you have one other question for Sophie.
Yeah, there's one question again for Sophie. Do you do PRP injection at G-spot? The difference between the nanofat graft and PRP injection at G-spot?
So yes, I was doing PRP injection 10 years ago. It's also effective, but you need a lot of session. We need 3 sessions 1 month apart, and then we need to redo 1 session every 3 months. And also the result is it's less effective. So I stopped doing this, because with just 1 session of nanofat grafting, we obtain a long-lasting results and better results.
Okay, I think we have answered most of the questions. From here, we'll move on In fact, thank you very much to the three panelists, Dr. Sophie Menkes, Professor Guy Magalon, and Jeremy Magalon. And my sincere appreciation and thank you to three of you, and especially Professor Guy Magalon, who has taken a lot of effort to help us to organize the upcoming FETS Bangkok event in June 23rd, 28th to 30th of June, where we have panelists of great speakers around the world that is coming to Bangkok and meet you. And this is the main congress. As you can see, we have a pre-conference instructional course, which will be chaired by Professor Guy Magalon, Dr. Jeremy Magalon, and Dr. Sophie Menkes. And on the 29th and 30th, the rest of the faculty speakers from all the countries. And post-conference, we also have the hands-on cadaver masterclass by Dr. Ares Sterodimas on the facial and also the breast stroma enriched lipogram. So with this, okay, as this is our dates. If you want to join, you can register through the www.fetch.my, and or you can scan the code for the early bird tickets. So without further ado, thank you very much for everybody for taking their precious Sunday to join this webinar. And we will have another schedule in 2 weeks' time for another webinar by another distinguished speakers. We will keep all of you informed about the upcoming webinar as well. So with that, thank you everybody for your time. Thank you very much.
Thank you, Eddie.
Thank you.
Thank you very much.
you,
three of you from Europe. It's lunchtime over there, and it's the dinner time in Southeast Asia, most of the Southeast Asia countries. Thank you very much. Good night and good afternoon to three of you. Thank you. Thank you.